We're 2 minutes in. I think we'll get started. So thank you again, everyone, for joining us. You are here at the Advancing Mental Health Through Asynchronous Therapy webinar. I'm super excited about this topic. We have an all-star panelist with us today. Just some quick housekeeping. Please submit questions that you have in that little Q&A box at the bottom of the Zoom. We'll be capturing those and we'll be able to answer them at the end during our Q&A section. And for those who are wondering if you'll be able to get access to the webinar afterwards, yes, you will. Everyone will get a recording. So without further ado, why don't we go ahead and introduce our amazing panelists, starting with Dr. Hull, and then we'll go down the list, please.
Thanks, Salome. I'm thrilled to be here with Going Digital. Appreciate it. So I'm Derek Hull. I'm a clinical psychologist and researcher, and I serve as the research director at Talkspace.
My name is Dr. Varun Chaudhary. I'm the Chief Medical Officer of Talkspace. I'm a board-certified forensic psychiatrist and started practicing telepsychiatry in 2006. So very excited to be here. Thank you.
Pablo McCabe, LCSW, and I just want to echo again how excited I am as well. My title is SVP of Healthcare and Account Strategy here at Talkspace. Brooke?
Thanks, Pablo. Very excited to be here as well. Brooke Wilson, I head up Resources for Living, which is one of the mental well-being offerings as part of CVS Health's services. Resources for Living offers a variety of different mental well-being services, including EAPs, social determinants of health, work-life services, and we've really been on a path to transform and reimagine mental well-being and focus really on navigating and connecting people to the right care across that mental well-being spectrum.
Thanks so much, everyone. And I'm Salome Tibabu, the host of Going Digital Behavioral Health Tech. For those of you who don't know, we'll also be joined by these lovely panelists at our upcoming Going Digital Behavioral Health Tech Summit. It's June 8th and 9th, free to attend for anybody. So definitely please register. And now, without further ado, let's jump right into our conversation. Dr. Hull, I want to start with you. What is asynchronous therapy? And maybe you can talk to us a little bit about what are some of the common clinical misconceptions or questions that you've typically come across?
Sure. Yeah, you bet. So I think the easiest way to think about asynchronous messaging therapy is, you can imagine what it's like to text a friend, except imagine that your friend is a licensed healthcare professional who responds to you within a certain frame of care. Many years ago now, when we were first exploring what it would mean to deliver psychotherapy through asynchronous messaging, or what I may call texting or just messaging later, since asynchronous is such an ugly but sophisticated sounding word, but still ugly word. It was designed to solve a couple problems in care delivery. So one is that, historically we've not had enough providers. So is there any way of allowing providers to serve more people? And it seemed like messaging would be a way to solve for that. Another one is the inconvenience. Even if you have the money to seek care, which some people don't, scheduling the sessions can be a challenge. The travel, the commute, all of that can be a challenge. So is there ways of allowing people not just to deliver, or allowing providers not just to deliver care at home, which you could do through video, and that was, of course, very common 10 years ago, but also to allow the care to fit into the schedule of people who are very busy or may have childcare responsibilities or a whole host of other things, so that the client member can fit the treatment into their schedule. But with those upsides, there was a huge question of what exactly is this going to look like? What does the clinical frame look like when you're delivering care in this way? And then, of course, as we'll talk a little bit about later, what are the clinical and outcome implications for delivering care in this way? Are there going to be trade-offs? Yes, maybe we get a win on convenience, but maybe we lose a little bit on clinical outcomes. Or there's a whole host of questions. And so very, 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 very early on in Talkspace's history, research was an important part of what we were doing, because we wanted to innovate this new care model, but at the same time making sure that it was being done ethically and responsibly, and that we could actually report on how it's working for people. And the second part of your question is an interesting one too, misconceptions. I think often, like when people hear messaging therapy, they sort of imagine like I don't know, somebody in a basement somewhere who's busy doing other things and only like checks in every now and then to send a message to their member or client. And a lot of work went into making sure that we had licensed professionals who can structure the treatment in the same kind of clinical frame that you would expect if you were going face-to-face or working by video. So there's an informed consent process that individuals go through. There's an education process that therapists take members through, clients through, to help them understand what are the frames of therapy, when can you expect to hear from me, what do we expect from you as you're participating in this treatment, how exactly does the messaging work. There's even an orientation to the kinds of messaging. So a lot of times people also hear like, oh, it must just be text, but the platform also enables audio messages that are recorded, video messages that are recorded. You can send pictures, you can share documents. So it's a very rich kind of experience, even though it's delivered asynchronously.
Excellent. Thanks so much. And speaking of outcomes, you've conducted some pretty amazing large-scale research on asynchronous therapy. Would love to learn more about that, please.
Yeah, you bet. And I think we have some slides maybe that we can share with the audience. And happy to get questions, of course, around this research. We can follow up on it later, or anything else that's of interest to you. So as I mentioned, early on, there were questions about what are the clinical implications of delivering care in this way. And so we, extended a lot of effort to ensure that we're tracking outcomes as a consistent part of what we do on the platform. So when people start treatment, we give them an industry standard assessment that's geared specifically to their diagnosis or the presenting complaint. And then we track these outcomes over time as a tool for therapists, which assists them in their treatment planning and tracking progress and working with the client on the symptoms that seem to be worsening. Maybe we need to focus more on those, or places where things are getting better, we can move on to other topics. And it's also a benefit to the client or member that's receiving the care so that they can kind of see where they're at, have a chance to check in with themselves and spur conversation with their provider. Over time, we've amassed a lot of data. As you can see here, a very large sample size, almost 11,000 people. And here we're focused specifically on depression and anxiety. Although as licensed healthcare professionals, our therapists serve individuals who have a variety of diagnoses, not just depression, anxiety, but lots of different presenting complaints, just like you would see, in a standard practice. Some interesting things to point out about these data, in addition to large sample size, is that folks come in, on average about moderately severe, at least in this sample. I'll show some data later where people come in with much more elevated baseline scores. And then you see, marked improvement over time for both anxiety symptoms, which is the GAD-7 that you'll see there on the scale, the blue line, and also for depression symptoms, which is the PHQ-9, which is the dotted gold yellow line. Many of the individuals that present for care on the platform, just like in face-to-face care, they're largely female. Early middle age, 26 to 35 is the majority, although we have folks, in their 60s and 70s that also use the platform. In this sample in particular, you see it's relatively well educated. About 75% have a bachelor's degree or more. And then on average, they stayed in care almost 10 weeks, which for a digital offering, 10 weeks in care speaks to the kinds of convenience that's added through asynchronous messaging. If you look at like face-to-face settings, I think the modal number of sessions is something like 2, so most people will go to 2, and then either it becomes inconvenient or cost prohibitive and they drop out. So we see an advantage here for the convenience aspect of this delivery model. And then the outcomes, about 48%, we would say, clinically significant change is just a fancy way of saying that they started above some clinical threshold, ended below that clinical threshold, and then improved a certain amount. So it's a nice measure of meaningful clinical change. And these percentages, nearly half meet that high bar. An additional 20, 25% in each case also improve, but don't quite, fully recover. And encouragingly, when we publish this paper, these kinds of outcomes are on par with what you see for other traditional types of care. So it seemed like there's something happening asynchronously that is allowing the mechanisms of therapy that are helpful for people to continue to flourish and to reach more individuals. Let's go to the next slide. Now, when you have a large sample like this, I think this is really, really interesting. And if there are clinical researchers on the call, I would encourage more people to analyze their data this way if you have a large enough sample, because hidden within that simple line graph are lots of different kinds of outcomes, right? We all know that not everybody's going to improve as much as we would like in healthcare of any kind. Some people are going to improve rapidly, some people are going to improve more slowly. And what this little representation here shows is that we can do a kind of unsupervised machine learning method called latent growth mixture modeling that allows you to pull these different kinds of subpopulations out of a larger sample. And so if we go to the next slide, you'll see that we identified 6 populations like this, which can roughly be grouped into 3 types. So on the far left-hand side, one type is individuals who recover very rapidly and have a significant amount of improvement. This middle group are folks who take a more chronic course. You see there's some improvement there, but generally their symptoms remain elevated. And then the final group, and again, I'm sort of clustering these 2 groups together, but the final 2 groups on the end, which we can cluster into one, are folks who have a sort of gradual improvement over time. What's great about this analytic method is then you can see the percentages at the top of each graph that tell you what percentage of that sample had this kind of outcome. So that alone, I think, is interesting for clinical purposes, just to get a sense of like how well this is working and for whom. But more importantly, once you have individuals broken out into these groups, we can now start to look at what contributes to this kind of outcome. So going back to the left-hand side, individuals who recovered rapidly, we see that the client or member sends more words than other individuals, and they tended to have a slightly higher education. If we move to the chronic group, you can see that therapists have a sense of how well individuals are doing. So when individual symptoms are not improving as fast as we would like, we see more therapists' words. They're trying to reach out, they're offering more resources, they're offering more support. And I think this also works against a kind of misconception, which is that therapists hardly know what's going on for clients through text. I can say just real quick, sort of autobiographically, that when I was working with clients on the Talkspace platform for a couple of years, one of the things that stood out to me, and I heard this from other clinicians as well, is that because messaging is unfolding daily, you almost have more insight into what's going on with the client than you do weekly, where you're sort of relying on their memory, you're relying on what they choose to tell you, don't choose to tell you. But through messaging, because they're sharing things that are in the moment, you can have, I thought anyway, a stronger sense of what's going on for people day to day with that medium. And that's reflected here in these data that therapists are in tune with what's going on. And then finally, on the right-hand side, with the folks who improve gradually, and this is a nice finding in any kind of research, right? Where you have these 2 extremes, and then you would like to see the middle kind of fall. You want the predictors of what's happening in the middle to fall in the middle as well. And so we see an intermediate word count for both clients and therapists for the gradual improvement group. That is, the clients sent more words than the chronic group, the therapists less words than the chronic group, and then, the intermediate group sent less words than the group that improved more rapidly, but more words than the group that improved less rapidly. So there's a nice dosage effect there for the words that are shared, and they fall right in between these 2 extremes. Now, another thing to say about, so this is one study that we published. We have 6 or 7 others that have been published, a couple others that are under review. And what's nice is that these kinds of outcomes are really robust. So this isn't unique to this large sample. When we look at other kinds of populations under other kinds of conditions, we see very similar outcomes to these. And we've also run a series of case studies with some of our partners, and we find very similar outcomes in each of those case studies as well. So this finding has been replicated almost 20 times at this point, which is very, very exciting. In fact, let's look at one other study. Let's go to the next slide here. Because one question we might ask is, what kinds of outcomes for something besides depression and anxiety? And we see very similar sorts of trajectories, people who take a chronic course, people who improve more rapidly, people who improve kind of in between, for PTSD as well. And we all know that PTSD is a difficult and impairing condition to treat. We see a slight shift in the demographics here. There's, it's still predominantly female, but more men than in the depression anxiety sample. They tend to trend a little bit younger, education's about the same. But another nice replication of the depression and anxiety finding is that the more words they send, education level, if it's their first time in therapy, that was a new finding for PTSD, then they tend to have better outcomes on this platform. Now, next question is, so the clinical outcomes so far look pretty good. They look pretty comparable to what we expect for other kinds of care. But as people improve symptomatologically, in terms of, feeling better, do we see carry-on effects to their work life? And we have another study here that I'd like to talk about briefly to show a connection between their improvement in symptoms and their change in work-life balance. We could go to the next slide. So here again, focused on depression and anxiety, mostly due to its predominance. A smaller sample size here, but a very focused study looking on what's the impact of symptom improvement in terms of employee productivity and quality of life. And remarkably, as you see symptoms improve, well, I say remarkably, I mean, any HR professional would probably expect this, and Brooke may speak to this some as well. As you see individuals improve in terms of their symptoms, you do see improvement in their employee productivity. You see a decrease in presenteeism, which is sort of showing up to work, but not really being able to be that productive. We see decreases in absenteeism and significant increases in their activities outside of work. So in other words, they're able to leave work sort of in the workplace and then engage with their life later in the day. Let's go to the next slide because it gives a slightly different representation of the workplace outcomes. So you can see folks are missing 50% less days of work, which if I recall from the study adds up to something like 90 hours over the course of a year, which is more than 2 weeks, which is a significant improvement and increased productivity. And when they're at work, they're 36% more productive. And then, as I said, these carry on into their work-life balance and overall well-being also. So all very exciting. Now, folks who are familiar with research might say, well, but these are convenience samples and this is observational data. What would happen if you ran a randomized clinical trial and compared messaging-based care to weekly video-based care, a more kind of traditional approach? Would we see any differences there? So I'll talk about that next on the next slide. We secured funding from NIMH to run the RCT that I just described. And I think what's interesting about this design is that participants are not individuals who are coming to the Talkspace site, say looking for message-based care. Instead, we worked with a mental health advocacy organization and received referrals from them. So these are individuals who are just looking for mental health care, not necessarily messaging, not necessarily video, what we would think of as someone who's on the search for a solution. So that's a nice sample to pull from. In addition, we also randomized individuals within therapists. So, we don't want to have, say, better or worse therapists or more experienced therapists in the messaging condition relative to the video one. So every therapist gets half video and half messaging to control for that. And we ran a small pilot study with about 60 people, and you can see the results here on the left. We see that messaging only had slightly better retention, probably due to its convenience effects. No differences in demographics, so we had good randomization, and we see the exact same improvement across clinical measures and working alliance measures, which is just this WAI score is the working alliance inventory, which is a measure of how strong the relationship is between a therapist and their patient. So no difference between video and messaging, which is often another worry, that people don't feel as connected to their therapist through messaging, but we found no difference in this case. And then we had a small effect that messaging was slightly superior for the Sheehan, which is just a measure of general life disturbance. We followed this up with a larger study, about 215 people. On the next slide, please, Salome. Again, randomizing individuals between message-only care and video-only care. We follow them across 12 weeks. This data, by the way, is all collected by our collaborators at the University of Washington. They collect it, they analyze it. It's an independent evaluation. And there's so much about this that I could say, and maybe the questions will allow us to get into it some more, but let me just hit some highlights. One, if you look on the left-hand side of the graph, notice how high those scores are. An average of 17 points on these two measures is considered pretty severe. So these are individuals who are really suffering. You can also see marked improvement in both conditions over 12 weeks, where you see the average individual starts very high and then falls below the clinical threshold. That is, most folks get better in both the text and the video condition. And again, we replicate this finding that there's no difference in clinical outcome using these scales between message-based care and weekly video-based care, which is remarkable. And the other thing that we replicated in this study is the superiority effect for messaging in terms of engagement, that people engage more frequently, and they also tend to stay longer in care. Again, our assumption here is due to convenience effects, and some of the focus groups that we've run suggest that individuals preferred in a lot of ways asynchronous over video just due to how convenient it is and their ability to mesh it into their life. Let me talk a little bit about who's in this sample. So let's go to this next slide. Thanks to the referrals from the mental health advocacy group that we were working with, again, we see predominantly women, although as I've said, that's not unusual for psychotherapy research or psychotherapy in general, but a very diverse population. A lot of Latinx individuals were in this sample. We see education level is different than the data I had presented previously. So it's nice to know that an individual's education level can vary to some degree and still benefit from asynchronous message-based care. They tend to be a little bit younger, 30 years old. And then the average yearly income also suggests that these are individuals who are economically vulnerable in some way. And which is a nice way of buttressing this idea that asynchronous messaging can work for lots of different kinds of individuals across lots of different kinds of circumstances and clinical presentations. So very, very happy with these results so far. We have a follow-up phase 2 as part of this grant where we're going to recruit 1,000 people, do the exact same procedures that I've talked to you about today. And so at the end of this year, early next year, we'll have results for the larger sample, and we'll look forward to presenting those when they're ready. I think that pretty much covers what I had here, Salome. Thank you.
Thank you so much, Dr. Hall. That was remarkable. I can see a few questions coming into the Q&A box. Just a reminder to keep those coming, and we'll address them at the end of the conversation. In fact, let's see, I think we might even have time to capture one that's really interesting here. Maybe Pablo, I'll put you on the spot for this one. People want to know a little bit more about who are the types of organizations that you're working with typically. Tell us more about employers, payers, or EAPs that Talkspace serves and their needs today.
Sure, thanks, Salome, and Derek, thanks. I think the data is exciting to really look at the advocacy of async. And as we're known for is async, but we also provide live video sessions as well as psychiatric eval and self-help tools. So really trying to take async and combine it with options for live video, psychiatry, self-help to really offer a holistic approach and a wider, right? The idea is to widen the access and allow more people. And so we work on the consumer side, so direct to consumer. We also work with employers directly. And then really a large part of our growth on the enterprise side is to work with both payers or insurance companies who hold both commercial insurance, self-funded groups, as well as they may offer an EAP or wellness product. So depending on how we sit within the insurance payers, we can support them in a number of ways through partnership, offering async, live video, psychiatric evaluation. On the EAP side, we mostly offer the therapeutic interventions along with the self-help. We also work with a number of independent EAPs as well, who also look to us because we sit in network and allow folks to move, because once you begin that journey, some people are great at a brief intervention model. Formerly, I was an EAP counselor myself, and that allowed that. But we're also able to support our client companies because we know that when you open people up, they then need to continue their work. And that might be for a number of months, maybe longer. As Derek has shown, we do measure outcomes. And I think that is what is exciting about the folks that work with us and why we do and how we work is to get a little more detailed. We also offer both monthly and quarterly reports that really look at utilization, but also outcomes to the measurements that Derek referred to. So we support our enterprise business in better having, because before that, how did we measure outpatient visits? And so we're able to capture this in a way through the various ways, async, those bad words, right, Derek? Messaging therapy, as well as other ways, as well as live video. We also offer live chat now. So again, the idea is to offer multiple to EAP payers, and then of course also consumers.
Okay, thank you. And speaking of people you work with, I think I'm going to pivot over to Brooke. Would love to hear a little bit more about your experience with Talkspace. In fact, what did you think about Talkspace's asynchronous solution the first time you heard it?
Thank you for that question. I'm going to echo some of what Dr. Hull and Pablo shared. Initially, it was really around being able to have a multi-channel offering for our customers. We were providing traditional types of support for people from a mental well-being perspective, and asynchronous chat was really interesting to us. We thought it would allow people another choice in how, in preference and how they might like to access care. It was convenient, as Dr. Hull talked about. And we did think that this could attract new members who maybe weren't engaging with those traditional means. It reduced barriers. It was less stigmatizing. It wasn't something where you had to, make a call and make an appointment and drive to see a provider. So for all of those reasons, we really were very interested in that asynchronous offering. At a higher level, it really also fit in with our strategy around thinking about technology and how technology can enable our human interactions. And wow, Talkspace just, they really fit the bill on that and being able to tie that together without losing the humans.
Excellent. And now, how about after you've had a chance to have some experience with it and see this data, what's been the reception like for your clients at Aetna Resource for Living and using Talkspace now?
Yeah, so certainly that convenience factor has played out. We saw this particularly during the pandemic. We have customers who are hospital workers or teachers and folks that don't have a lot of time. So that was a huge value to our customers. We also can produce and show the outcomes that Talkspace therapy has. That's not typically an easy thing for an EAP to do when we're working with across community providers and they're on, they have their own mode of care and their own systems. So just like Dr. Hull shared, we've seen very similar population results as well in terms of improvement in clinical outcomes and some of those work and school outcomes as well, which have been really exciting. And then I think I'd say that the other piece of this is that Talkspace has allowed us and our customers to really promote well-being and the importance that people have placed on well-being, particularly as they've reprioritized as a result of the pandemic. So it's coming to employees and their members with something new and something that fits their life perhaps better than some of those traditional methods that are out there.
And I was drawing from what you were saying, it sounds like the populations you serve are quite diverse as well for Resources for Living. Is that accurate?
Yep, absolutely. We're probably in every industry. We cover every size of employer and organization. So we're, like I mentioned earlier, we're serving hospital workers, we're serving retail, airline workers. So really goes across the board. I want to add, though, that we also offer Talkspace not only to that member, but to their family. So we can support that full ecosystem that is around that employee or member, significant others, the family members, the caregivers, and that really just helps us to really bring mental well-being into people's everyday lives and make it something that is that lower barrier for access.
And Brooke, you actually, you reminded me, I think also is we've made it available and working with you all and talking about that is making it available to 13 and up on the therapeutic side. And then psychiatry, available to 18 and up for now, although I know we're looking at expanding adolescent psych care as Dr. Chowdhury leads the way. But, I think it is interesting. And I think where we get interest in why this is an exciting webinar, right, Brooke, is that data can be fun, data can be exciting, and that it can be really helpful in looking at certain populations, like you said, and that our therapists and Salome, I think, that's the key too, is to have a therapy population, one that's been vetted, but also has specialties that are able to work with various populations, right? So as well as clinical approaches, and I know Dr. Hull and Dr. Chowdhury can talk about that, but we have folks that have various backgrounds, and we look for that diversity. And I think that's important. My time in the industry, even before Talkspace, when I was with Hazelden and Betty Ford, I think we always looked to bring in folks that had different approaches to widen, again, our ability to work with more people, right?
Thanks so much. Brooke, one more question. It sounds like you have evolved your solution suite with Talkspace. Is that accurate? You started with async and doing some other things as well?
Yeah, we have. We started 2017, 2018, I think, Pablo, talking together. And as part of our mental well-being innovation, we actually started with a pilot with Talkspace. So Talkspace was one of the new ways to engage members that we wanted to try out. And so when we identified some pilot customers, we added Talkspace as an option, and we learned how to best engage people. Like if we, as an example, if someone lived in a place where there weren't a lot of providers, that could be a trigger for a Talkspace referral. We also learned that by promoting Talkspace, we had customers in this pilot who promoted it, and they saw utilization of the EAP program jump 20% in just 1 month. It's a different thing to talk about. All of a sudden, we were getting to different members who maybe had not used services before, and that was all the async. So then now we move into pandemic times, and we're seeing increasing demand for mental well-being support. Those traditional providers don't have appointments. They may not even open and haven't maybe fully transitioned yet into more of a telephonic or a video option. We were also at the time seeing that need for provider matching and diversity, and making sure that there was that, as Pablo, as you just mentioned, just making sure there was that ability for choice for a member. That was also something that we knew we needed to solve for. But you know what, we had Talkspace. We already had a partnership. And so while we were having trouble finding that availability as providers and that macro environment started changing out there, Talkspace grew their network. At the same time, we also were able to offer these different modes of connection beyond async. So for our customers, we have that option of a telephonic session, a video session, a live chat session, as well as that asynchronous. And so even a member within an interaction or within an issue can kind of switch in between, which also gives them that full support, perhaps between a session, where they're able to still stay connected with their therapist.
Excellent. And now I'm sure that many audience members are thinking about how can we practically put something in place like this. Dr. Chowdhury, I'd like to pivot over to you. A question that we got ahead of the webinar was, how do you enforce boundaries with clients who expect emergent 24/7 access?
Thank you, Salome. So one thing I'm going to say is, when I was in private practice as a solo practitioner, I would give my cell phone number to all my patients. And then I would emphasize that it's important that they realize this is for emergencies only. And it was technically 24/7 access. I rarely, if ever, got called. I think it's very important to really emphasize that there is a certain empathic connection that goes with boundary settings. And it really will help improve the therapeutic relationship when there is that transparent exchange to allow people to understand that it's not a 24/7, anytime you need it, there's somebody right there. It's really going to be important to set those boundaries and have that understanding right from the beginning.
And semi-related follow-up. What conditions or severity is asynchronous therapy potentially not appropriate for?
The way I approach it is to really look at it as a goodness of fit between the therapist or prescriber and the patient. And so it's really more of an understanding of what asynchronous chat-based treatment is, what it's not, and really making that connection. Some people will have a learning curve and there'll be a transitional period, and then it becomes second nature. So it's more of an option looking at it from a spectrum perspective. Obviously, those who have greater needs are going to need a lot more support than just this. But this is a tool to really for us to meet our goal of increasing access to high quality therapeutic and behavioral health care.
And I think that's an important question that sometimes, what isn't, if you're an outpatient therapist, there's a number of levels of care that aren't appropriate. And that when somebody needs a higher level of care. So when we're talking about levels of care, we need to think about, what service is being delivered. This is an individual, maybe couple. And depending on their needs, there's an assessment period, right, Dr. Chowdhury, that within a few days that a clinician really works to create a treatment plan, just like an outpatient in-person therapist would. And so there at that time, and actually to your point, Derek, through asynchronous, you can see over the days where somebody might be escalating or de-escalating, right? And understanding what's needed. I remember in my private practice, I got to see somebody once, and then I had to quickly make some informed decisions and then kind of wait. And like Derek said, based on memory and interpretation of events. Whereas as they write something down and submit it, knowing the therapist with boundaries will get back to them within business hours, like Dr. Chowdhury said, we're able to track that. So in some ways, the questions being asked of async should always be asked of anybody doing outpatient level. What are you capable of doing? And when do you need to make a referral?
Excellent. These are all really great questions, and rather great feedback, but I want to make sure we have enough time for questions. So I'm going to go ahead and make sure I pivot us over there. Wow. Thank you, everyone. We've got tons of questions pouring in here. Let me try to get through as many as we can. First one, let's see. Would love to hear more about the provider experience. How do you train, support text-based provision of care? Maybe Dr. Chowdhury?
Certainly. We've got a very robust training program. What we want to do is when we have providers who are coming in wanting to be part of Talkspace, we have a full comprehensive onboarding process, and the training includes practical things such as how do you do chat-based treatment, but also looking at all of the necessary requirements, HIPAA, security, confidentiality, risk management, crisis training. So we've created a program specifically looking at the risk management question based on SAMHSA's guidelines on behavioral health crisis management. And we've also incorporated the Columbia Suicide Rating Scale training for that. So anytime one of our providers is in a situation where there might be some thought of suicidal ideation or behavior or something like that, there is a full protocol that they can follow. And we also have contracted with a third-party vendor that has 24/7 crisis management access. And so we make sure that all providers have that information, that number.
Great.
On that, just real quick, if I can just add a little bit, and I love what Dr. Chowdhury said. As therapists come in, often the biggest learning curve is sort of breaking the expectation of getting all the information at once. Like as we've worked with therapists, part of it's a training of like the information is going to come in every day. You don't have to get 45, or if you work in a VA, you do like a 90-minute BIC. You don't have to get 90 minutes worth of data on the very first day with these patients. And it gives therapists some time and patients some time as well to get a sense of like, what is the story? How do I want to respond to this? What's the most important information I could share with this individual? There's something about buying time for the provider that once they get used to is a big benefit.
Absolutely. Let's see. How does asynchronous care impact the retention rate through the course of care? And is there any impact on duration of care or remission?
So I'll start that, but Dr. Chowdhury, I really think that's you and Dr. Hull. Although when I think about this and I think back to my days as individual practitioner, EAP, direct care, as well as working at higher levels of care, my ability to pause, and I'm speaking to all the clinicians. How many times have you been sitting in front of somebody and you're really trying to understand them, clocking your words, taking into account what they're doing, and maybe post-session you thought, I should have asked that. Because you're trying to move so quickly through the session in assessing and understanding and building rapport. There's a lot that goes into one session. In an async fashion, it allows us to begin to really establish a connection over time and over cadence. And also, I get to pause for a second and really think, what did they just write me? What could this mean? And how do I want to respond? And I may begin to type, and then I may back up. You can't do that verbally. And so what you have to say is, well, what I meant to say was, let me try reframing it this way, or what do you think about it this way, versus actually writing it in that asynchronous fashion. You have that time. And I do think also what we then do is try to measure how therapists engage folks. And I think that's key to retaining, is we're measuring how people connect with their therapist, and also how the therapist is engaging. And Dr. Hall and Dr. Chowdhury, I know you all can speak about this as you're in the trenches with the clinicians really looking at this. But I believe async has a great ability, from what I understand, to allow somebody to really stay engaged, and therefore we usually see higher retention rates. I don't know, Dr. Chowdhury, Derek?
Yeah, Pablo, actually, I was going to agree with you in the sense of, when we have that feedback informed care and looking at it from a measurement-based care perspective, there is a ongoing dialogue, if you will, and there's that connection that's made that it ends up being a lot deeper than just a weekly session or something of that nature, because there is that feedback and there's that emotional connection that can occur. So from my perspective, looking at it from a retention perspective, I think, again, when it comes down to that goodness of fit, when you have a good fit, then that becomes a very good measure of engagement and improvement.
Yeah, and if I just speak to the data real quick, I think Dr. Chowdhury hit it right on, hit the nail on the head, which is that, like, some people are going to want a weekly video session, and that's okay. They should have a weekly video session. Some people are going to want to meet with a provider in person. Also, totally fine. They should meet with a provider in person. But there are some populations that Brooke highlighted that we see really powerful data for, which are like healthcare workers, airline workers, young moms, again, are another one that's like asynchronous care is very like a lifeline for a lot of these individuals. And so when there's a good fit between the medium and the circumstances of an individual's life, then yes, in general, as Pablo said, and as Dr. Chowdhury confirmed, we do see an increase in retention and engagement with async care.
That's such a lovely place to unfortunately end on. We've got tons more questions, and for everyone in the audience, we'll make sure to capture them and follow up, but we are at time and I want to be respectful of everyone's time. Thank you, Talkspace, Aetna, Brooke, thank you for sharing your insights and experiences. It's clear that you're passionate about making sure that folks get the mental health care they need, where they need it, how they need it, and you're really providing optionality through these kinds of modalities. And so I'm really excited about this work and looking forward to continuing the conversation at the conference coming up next month. And for folks interested, we will follow up via email on the questions that we couldn't get to, as well as how you can learn more. So thank you.
Thanks, Salome. Thanks, Brooke. Thanks, Dr. Hull. Thanks, Dr. Chowdhury.
Thank you all.